So we're here on a sunny day in December of 2020 with Dr. Karen Green, the first perinatologist in Worcester at UMass Memorial Hospital. Welcome.
Thank you.
So what drew you to a career in medicine? What made you make that decision?
Well, my father was a physician. He was not a practicing physician. He worked at NIH for over 30 years and did mostly research and administrative work there. But I was always fascinated by medicine from that point of view. And I liked science and I liked music. And so I applied to the University of Rochester, which had Eastman School of Music and had a science department and a medical school.
Mm-hmm.
When I got there, I was pretty amazed at how cold it was. And why? Because I grew up in Maryland. So this was quite a change in many ways. But my grandparents lived in Rochester, so I had somebody to visit and be near.
Mm-hmm.
And at some point it dawned on me that I was never going to be good enough to be a professional musician, number one. And number two, it wasn't a good way to make a living either. So science won out. And I went from Rochester south because I was cold, and I went to medical school at the University of North Carolina in Chapel Hill. And that was much better environment.
Yes.
Although culturally it looked very different from,
Sure.
This was 1968. This was the protestations, the riots in Chicago and everything else. And in North Carolina, it looked like the major concern was whether you had shoes that matched your outfits for the day. It was a very different place, but warm.
Okay.
It was also one of the first schools to have a pass-fail system.
Mm-hmm.
So we didn't have a letter grade or a number grade. You did have, excellent and, high pass and things like that. But it wasn't quite as stressful as pre-med education was as far as grades go.
Yeah, I'm sure even in those days, pre-med was just extremely stressful. And how big was your class in North Carolina?
72.
And how many women were in your class?
4.
Huh. And did you tend to work together with the other women, or did you just kind of blend in with everybody?
I would say 3 out of 4 of us worked together. Although we didn't study together, I had one as a roommate the last 2 years.
Mm-hmm.
But we did a few things together. We were not alphabetically in the same part of the alphabet, and a lot of things were done alphabetically. So I was at the end of the alphabet and was by myself, more or less.
Sure. Interesting. And you just progressed through this. This sounded like you came from a medical family. You had some aptitude in science, and you made a logical decision. Did you feel at that time that there were any barriers for you because you were a woman?
Not in my undergraduate studies. Applying to medical school, I was concerned.
Mm-hmm.
Some of my friends in college were applying to the Women's College of Medicine because they thought they could get it in there better than anywhere else.
Mm-hmm.
But I think I was pretty much encouraged to apply wherever I wanted. I stayed on the East Coast because my family was there. But and interesting enough, the schools I got into were in the South, and more than up north, and that was fine with me.
Sure. And within medical school, did you feel that there was a high stress environment, or did you feel that the pass-fail system and a sense of collegiality, perhaps among your fellow students, how did that work out?
I think among students, I didn't sense any discrimination or problems with being a woman. Although they didn't socialize with the women in the school as well as they did with each other. The men, but a lot of the men were married, and so they had different social context anyway.
Sure.
I did send some from the faculty and staff because they, orthopedics department had never seen a woman rotate through there. They were not particularly friendly. Anesthesia was not very friendly.
Sure.
But other departments were fine.
Sure.
And my first rotation was OBGYN, and I just loved it from then on. I always thought I was going to go into medicine because that was what my dad was in, but I liked OBGYN right away.
And so you made the decision to go into OB, and where did you do your residency?
At the University of Pittsburgh. And McGee Women's Hospital, which is, at that time was doing 10,000 deliveries a year. There were 8 in my first year program. And it was the first year that you could match directly into residency without doing a rotating internship. It's sort of the first time they tried that at Pittsburgh. And I was the only one in that program until my senior year.
So in your year or in the whole program?
In the whole program.
Really? So they had 8 per year.
Yes.
So 32 residents, 1 woman.
1 woman.
Okay. And how did that? Did you feel welcomed, or did you feel that you were running by a different standard?
I did feel welcome. Even before I got there, I have to tell you, the unique thing was as I was applying to residency, I got invited by the University of Colorado to come out and interview because they wanted a woman in their program. They didn't have one. So I did go out there and look, but it was too far away from home. So it was still pretty rare at that point in time. And again, OBGYN was sort of a surgical subspecialty, which just didn't have women then.
And this was at a point in time, what sort of on-call arrangements, what was a work day like for you during your residency?
In residency, we were on essentially every third night. And we rotated through an ER, NICU, GYN, and OB. It's very different than now, though, because you did a lot of things totally independent. The faculties were at home. You'd call them on the phone and tell them what was happening. You got to do a lot of procedures that even residents today don't do.
Sure.
We ran an OR without the faculty member even being there.
Wow. And were your patients clinic patients or private patients?
We had both.
Yeah.
It was a large clinic.
Yeah.
Because it was the major maternity hospital for the city of Pittsburgh. There was others that did OB, but relatively low volume.
So this was an era in which these clinics were set up to provide charity care, and the residents were running with fairly distant supervision from the attending physicians. You got experience, but perhaps would have enjoyed a little more oversight.
Well, you learned a lot from your resident above you.
Sure.
And in some cases that was good, I'm sure, but other cases it was not optimal. We did have a perinatologist then. It was one of the first in the country.
And this was early 1970s.
Yes. Richard Depp, who is one of the grandfathers of the major of the subspecialty, and so that was nice. And we had the GYN oncologist at that time was also a general surgeon, so we scrubbed in on head and neck surgery, breast surgery, as well as GYN surgery.
Wow. Interesting experience. And in those days in obstetrics, do you recall what the cesarean section rate was?
No, I don't. It was just starting to use fetal monitoring when I got there.
Yeah.
And not every patient was on the monitor.
Sure.
So I'm sure the suction rate was starting to go up. It was also one of the first places to offer epidural anesthesia
Okay.
in OB. And so, but it was one guy who could do it.
And
So if he
forceps?
wasn't on, you didn't get it.
Right.
Did a lot of spinal anesthesia myself.
Uh-huh.
Um,
And forceps? Did you get trained in
we
using
did
forceps?
forceps. We didn't use the vacuum much.
Sure.
Now that's sort of taken over. But
Right.
yeah, we did forceps and forceps rotations, which people aren't trained on now.
Mm-hmm. Mm-hmm. And if a woman came in with a breech in labor, would she be sectioned automatically? Or?
No, we did vaginal breech deliveries.
Sure.
I do remember one situation where we were inducing twins,
Mm-hmm.
and they were breech vertex. That would never be done 5 years later. Right?
Sure.
Because they was concerned about the second one, but
Sure.
we did it then.
Yeah. Yeah. So,
And I had one surprise set of triplets. The doctor knew it was twins, but then all of a sudden, oh, there's another one, because they didn't have routine ultrasounds.
Right. And also you did not have a lot of infertility treatments that led to multiple pregnancies.
That's right.
This was before in vitro fertilization, and even inducing ovulation was not nearly as common.
Yes, and we did amniocentesis. I did amniocentesis, but it was blind. We
Mhm.
felt where the best pocket was and just did it. And I didn't have any major problems from it.
No.
Um,
And in those days, the other part was, do you have a rough idea of the typical age of a woman coming in labor?
well, they were mostly in their 20s, early 30s.
Mm-hmm. Yeah.
Advanced maternal age was rare.
Yeah.
We didn't do many genetic tests that way either.
Right. Right. It was not something that was commonly done.
No.
And this was also the period of time of Roe versus Wade passing. And I don't know what the state laws were in Pennsylvania, but did the whole abortion controversy impact you at all during your residency?
So at the time I was there, we did abortions, including second trimester abortions.
Mm-hmm.
It's much more strict in Pennsylvania now than it was back then. I don't know why it changed in that direction.
Mm-hmm.
But their laws now are much more rigorous, I think, as far as allowing abortion.
Interesting. Okay. Now, at some point during your residency, you decided to do a fellowship.
So I always liked obstetrics more than gynecology. I just felt more comfortable with it. I didn't feel as comfortable with the GYN surgery. And then other things come into play. My husband was on the Berry plan, had to commit to 2 years of service because of the Vietnam War. And so I knew I had to go 2 years someplace. And the idea of going 2 years in someplace and starting a practice or not, or joining or just working per diem didn't appeal to me. And at that time, the maternal fetal fellowship was just 2 years. So the idea was maybe I could get a fellowship where he was going to be stationed. And we were lucky that they had an opening in San Diego, and my husband could match in Oceanside, which is 30 miles away, and so we could go there. And the Navy moved us there, and it worked out perfectly.
Now, at what point in your career did you get married?
My first year residency.
Mm-hmm.
I met my husband as a senior in medical school. He was a resident in family medicine at a community hospital that I rotated through for an acting internship.
Uh-huh.
So then we went through this whole rigmarole of matching, him changing programs in the middle to go to a program in Pittsburgh, and then we got in sync.
Yeah. And children?
I have 2 sons. They were born after residency, fellowship, and then after I moved to Worcester.
Worcester. And so you did your fellowship in California.
Yes.
And what sort of experiences did you have there?
That was interesting enough. The University Hospital at San Diego was a relatively small program, compared to the delivery service I had in Pittsburgh, it was more about 1,500 or 2,000, not even. So it was very close supervision of everything and all the residents as well. Bob Resnick was the maternal fetal medicine attending, and he was by himself when I started.
Mm-hmm.
And he did morning rounds every single day. And we went through every case on the board and discussed it. And so it was a very rigorous education for the residents as well as myself. Mm-hmm. And then we did a research project together, which you had to do as part of the fellowship.
Sure. And particularly in those days, perinatology was fairly new. The average obstetrician gynecologist was used to doing their own deliveries. What sort of cases were getting referred to the perinatologist?
So at UC San Diego, this was mostly an inner city kind of hospital. So most of them were resident cases. There were not very many private physicians there at all. Mm-hmm. We went to a different hospital primarily. Mm-hmm. The perinatology service supervised the clinics.
Okay, so you oversaw all of the general obstetrics and then sort of focused in on ones that would be higher risk.
Yes, we had a diabetic clinic. We had, a few things broken out, but mm-hmm. and a high-risk clinic. But then some of the other clinics we supervised as well. Because mm-hmm. we pretty much covered labor and delivery all the time.
Okay. And what was your project in?
It was on the effect of magnesium sulfate on the newborn. So we did neurobehavioral testing of the newborn. Unfortunately, because the volume was not that big, we didn't get as big a numbers as we'd like, so I didn't really see a big effect of it, which I guess is reassuring because we're still using it today. But probably the numbers were not significant to pick up on null effects. So,
when you treated a mother with magnesium sulfate, did you measure blood levels, or did you just sort of use signs like reflexes or the like?
Yeah, we didn't do blood levels routinely.
Right.
We did reflexes and breathing, respiratory rates. We also, at least when I was a resident, did IM magnesium. Mm-hmm. But finally it was a IV by pump. Mm-hmm. And I can remember one time a patient was given Pitressin instead of Pitocin by mistake.
Oops.
Fortunately, Dr. Resnick said, let's check the vial quick, because they couldn't figure out why she was having trouble. And it was just scary. Mm-hmm. But everything turned out okay.
Mm-hmm. Okay. So you're finishing your residence or your fellowship. What sort of thinking did you do with your husband to decide where you wanted to practice?
Well, both our families were on the East Coast, so much as we liked California, every vacation was spent visiting one way or the other, and we decided we needed to be closer to home, particularly now that I had a baby. Mm-hmm. And so the idea was that we would look, since my job was harder to find because there weren't that many opportunities yet, the idea was he would pick the area of the country, but then I would find my job, mm-hmm. and he would find a family practice to join. Mm-hmm. He had gone to BU Medical School, so that's how New England came into the program. And it turned out, again, a lot of places were not ready. When I went to interview in Providence at Brown, the head of the department said, well, I think you'd have to build rapport with the community. I'm thinking, okay, I'm right out of fellowship. How am I going to do that? Uh-huh. And that was an awful big job. And you should do more research. Mm-hmm. I'm going, okay, how am I going to do all those things? Because this would have been the first fellowship for them, first faculty for them, mm-hmm. besides the chair. Mm-hmm. So, and the other was in D.C., another one that I looked at. But I grew up in the D.C. area, and I knew how much traffic getting to and from the hospital was going to be, and how I didn't want to add more time away from my child.
Sure.
than the work hours, which were bad enough.
Sure. And what was the offer like or atmosphere like in Worcester?
Well, again, I was the first person to come to Worcester, and they came, recruited me. Actually, we met at one of the national meetings for interview and discuss what was involved. And it was a new medical school.
Mm-hmm.
Dick Hunter was the only member of the department. He was the chair. And Saul Lerner came out and interviewed me. And so it was exciting to start something new.
Mm-hmm.
And when I came, everybody was very welcoming.
Mm-hmm.
And it was a small enough service then. It was about half of the size it is now. And so you could manage it pretty well.
Mm-hmm.
The only thing I didn't really plan was how I was going to take call for all this. And the very first night that I worked, the very first day I worked, and my husband worked, he got home at 9 p.m. and I got home at 1 a.m. And our babysitter almost quit on the first day. She said, "This is not what I planned." So there was a lot of scurrying around to figure out how to cross cover with
Sure.
Dr. Hunter, actually, Todd
Sure.
Hunter.
In those days, you were covering more than one hospital.
Well, predominantly UMass,
Yes.
Memorial Hospital. Actually, had a different name. Then it's changed names, I think, 4 times since I started.
Right. It was the Memorial Hospital
Right.
in Worcester, right?
But I was mostly there because I covered labor and delivery essentially every day, Monday through Friday,
Mm-hmm.
and then took call at night too. And so then you often sometimes did 36 hours straight, which was crazy.
Mm-hmm. And if somebody had a patient at St. Vincent Hospital, you might go over just to make rounds on them or do a consultation.
Usually a consultation,
Yeah.
not so much rounds, I don't
Yeah.
think. That was pretty rare, though.
Yeah.
I've did the same thing in Leominster occasionally,
Yeah.
and in Milford occasionally.
And initially, you mentioned this already, you were the only perinatologist
Yes,
in
I
central
can't remember for
Massachusetts.
how long, but it certainly was several years,
Mm-hmm.
and I asked for help more than once and was told, "Well, we don't have enough money, we don't have time, we can't hire another person at this time."
Mm-hmm. Mm-hmm.
But the good news was that the people practicing in Worcester were they've been doing this for a while. And Brad Griffin and Frank Bednarik were the neonatologists, and they had some familiarity with high-risk OB as well. And they had sort of filled in and given advice when needed before I got there, and we then worked together.
Mm-hmm. Mm-hmm. Excellent. And so at some point then you got a partner?
I did.
Mm-hmm.
And so then we just split things. Also about that time, we determined that we didn't have enough support to do ultrasound in the middle of the night when a problem came in. You'd have a patient come in and somebody didn't know how far along she was, or we didn't know if there was a problem with the baby or why she was being transferred. And that had to be decided pretty quickly at night.
Mm-hmm.
So William McLaughlin and I sort of started an ultrasound unit. We learned how to do ultrasound. And so that added to the responsibilities because that was now running every day as well.
And so what you're alluding to is the notion that initially radiology was running ultrasound.
That's correct.
It was not within the umbrella of the obstetrics department, and so you had to go through moving patients around, you had to go through scheduling and that sort of thing, and you brought that in.
Yes.
Okay.
And they were not that familiar with OB. They didn't like doing it.
Mm-hmm. Mm-hmm. Yeah. And anesthesia in those days here in Worcester for women in labor?
I think we got epidural anesthesia relatively quickly. I don't remember. exactly when it started, but
Mm-hmm.
I don't remember a lot of spinal anesthesia or.
Mm-hmm.
And they certainly had stopped inhalation support.
Mm-hmm. Mm-hmm. Okay. And in those days, probably the section rate was in the vicinity of 12-15% in the early 80s.
I think so, yeah.
Yeah, in that range there, but still using forceps.
Yes.
And just beginning later in the 80s or so to bring in the vacuum.
The other
And-
that changed pretty dramatically was when I came, they were using IV alcohol to stop premature labor. And I said, that's not a good idea.
Uh-huh.
Let me tell you about something else.
Uh-huh.
Now, the drugs we used even back then are not being used now.
Right.
And whether any of those work, I don't know. But we felt like we were doing something good.
Mm-hmm. Mm-hmm. Yeah, over the years, the treatments for premature labor have changed a fair amount.
Yes.
Alcohol was one of the earlier ones, particularly in the 70s or so. And then they moved to beta drugs.
Yes.
And then from the beta drugs, they moved over into using magnesium sulfate.
Right.
And so that has evolved over time, but the prematurity rate hasn't changed too much.
No, and they're not convinced that it really holds anything up.
Right.
I think maybe at best it held things enough for eventually us to learn to give steroids for the baby's lungs to mature.
Which didn't start until probably the late 80s.
80s, yeah.
Yeah, yeah. So that became available during your career.
Yes.
Okay. And another big thing that we would all need a perinatologist for would be the treatment of diabetics in pregnancy.
Yes.
And how did that change?
Well, the development of the glucometer was just earth-shattering to me because before that the patients had to go to the lab for their blood sugar testing because you can't use urine testing in pregnancy, and so we'd have them hang around the lab all day.
Mm-hmm.
They'd be eating hospital food, and which was never anything like what they ate at home. So we were
Mm-hmm.
really getting false readings as to what sugars were. You did the best you could, but it didn't work out.
Was
optimally.
it common to admit a woman who was pregnant?
It was fairly common. Yeah.
And how long would they stay?
Well, you try to get them in some kind of control, but again, they're not doing their daily activities. They're not eating their normal diet. So I think we were doing the best we could, but we recognized it wasn't.
They may spend
optimal.
weeks in the hospital during a
Yeah.
pregnancy. Yeah.
Particularly at the end,
Yeah.
because the stillbirth rate is higher.
Yeah.
And so we were afraid after all that work that something was going to happen at the last minute.
Mm-hmm. Mm-hmm.
So the glucoma is great. Now I understand we've got these transducers on the skin and everything else that even save that. But that's since I left.
Mm-hmm. Mm-hmm. And the treatments with insulin, as far as split doses and things like that, that evolved quite a bit. The whole goal of aiming for a normal blood sugar level was something that came upon during your career.
Well, it always used combination to some degree, but not to the specificity that we do now. And they didn't have as many options as far as kinds of insulin.
Mm-hmm.
They have a lot more long-acting things now that could even out the baseline.
And other conditions that a perinatologist would be called upon.
Well, one of the first things that was impressive to me when I came was the degree of heart disease,
Mm-hmm.
particularly rheumatic heart disease, which we don't see now. But back then that was pretty common, and
Mm-hmm.
Dr. Starobin and I used to huddle over what we could do for these patients and who had to go to Boston because we didn't have open heart surgery in Worcester.
Mm-hmm.
That still doesn't exist now. But
Mm-hmm.
that was an interesting thing, and we had a couple maternal deaths over the time because of bad heart disease. Not in the hospital, we had to send them, but they didn't make it even in Boston.
Right. And you also alluded to the fact that Dr. Bednarik, Dr. Griffin started the neonatal intensive care unit here in Worcester. And that also was something new for the region and led to improved outcomes, so that when you started your career, a 28-weeker probably wouldn't have much chance.
Well, 28 weeks did okay. But interestingly enough, when I came, they weren't very aggressive to anybody below 32 weeks.
Mm-hmm.
When I came, we were pretty aggressive with 28 weeks. Then it's gradually inched down to 24, maybe even 23 by now. I don't know. So that has changed over the time.
Sure, a tremendous amount of progress in that area, and the chances of a baby surviving and surviving healthy have increased.
The other thing that had been set up by Dr. Griffin was the regionalization of. Massachusetts was one of the first states to have regional perinatal care, and so that was already set up. But then we started going to each hospital 4 times a year, discussing their cases, whether they were referred appropriately or not, what they could do differently, offering education programs, that sort of thing, which continued.
And so in addition to simply being a person to whom people referred their high-risk cases, you also were expanding the skills and perspectives of the general OBGYNs who were doing deliveries.
I hope so.
Right. And so that outreach that you had was also part of your agenda.
Well, as much as Worcester was improving and learning what was going on, the other hospitals needed to catch up too, because that sort of service wasn't available.
And you also related to the fact that we've got a department that has been evolving, and when you were initially hired, the Memorial Hospital was your home base. The medical school was at University Hospital, and there was this sort of hybrid, this division of the Department of OBGYN, so that Memorial Hospital had the deliveries, and there was no obstetrics done at University Hospital.
That's correct. And GYN was done predominantly, at least in the referral, GYN was done at the University Hospital. Now the private doctors at Memorial did GYN surgery.
Right. And you also related the notion that Dr. Lerner interviewed you at an OB meeting, and Dr. Lerner was in private practice.
That's right.
And so the unit at Memorial Hospital, you were there as a employee, a part of the faculty of the university, but you were at a private hospital with all colleagues who were essentially in private practice.
Right, and I was paid by the private hospital.
So it was an interesting kind of arrangement.
It was a funny mix.
And you were okay with that when you were looking at practices and everything? You somehow got the sense that this was a good move.
Yeah, I think the idea was that it was a good way to start. I mean, most places didn't have anything set up, so it wasn't like a compare one to the other, because they each had their own ideas of what they were going to do.
You had to make a judgment, not so much about the structure of a known program, as about the values and sense of opportunity and welcoming that you were getting from the people you'd be working with.
Yes, and the other thing is that we never received any training as to how to pick a practice or how to manage a practice or how to do any of that. Now residents are involved in that education ahead of time, and they have, recruiters that teach them what's good and what's bad about each place, so that they have a little better experience of picking it out.
Yeah. And when you started, the residency was how many residents?
There were 3 residents a year, but the upper level years when I came were mostly foreign graduates, and there were only 2 chief residents and 1 third-year residents because they hadn't filled. about the time I came, I think the first year was the first year that they had participated in the match program.
Wow.
And so it was a full class then.
And so the department has evolved quite a bit. You had
Yes.
mentioned that basically there was Dr. Hunter,
Yes,
and then there was you.
that's right.
Okay. And over time, you grew the perinatology department to, how big
Well,
was it when you
I-
retired?
I think there were 6 when I retired.
Hmm.
My understanding is there are 9 now,
Okay.
plus 2 fellows.
Uh-huh.
Got 3 this year. Will be 3 fellows, one
Wow.
in each year.
Yeah. Good. And overall, the department has
Oh yes,
dozens. We'll
yes.
put it that way.
I don't know how many.
Okay. All right. So the other part of this is that when you started, there were, I think you said 36 residents at McGee Woman's?
Yeah.
Or no?
Well, there were 8 a year, but then they cut back to 6. So I don't.
Yeah,
Actually, I'm sorry. They were 10 a year, and then they cut back to 8.
Oh, okay.
That's what it
Over
was.
30, and you were the only woman.
Yes.
Now we've got roughly 16 to 20 residents in OBGYN. And how many are women?
Well, we count it the other way. There's maybe 1 man
Right.
or 2.
Right. So that's another transition that has occurred
Yes.
over the years. It has transitioned into a specialty predominantly of female physicians.
Yes.
And with regard to the technology, obstetrics has been exposed to so much technology. You mentioned when you started, they were just beginning to use fetal monitors, that ultrasounds were done rarely and were done in radiology. And, that technology has moved into much more mainstream. You mentioned also the fact that amniocentesis has advanced in some ways and is used for many more indications. In big ways, how else has obstetrics evolved?
Well, I'll go back to the amniocentesis briefly, and that is because we use it now less than ever because we can do so much with maternal blood.
Mm-hmm.
So years ago, when I was in a fellowship, they talked about at some point segregating out fetal cells from maternal blood so they could do the test. And sure enough, another 20 years went by and it still hadn't developed. Now they can do the genes, and so it's really changed dramatically. So A, you have screening tests, but B, you have blood tests that can follow up on those screening tests without an invasive procedure.
Mm-hmm.
By the same token, occasionally you can't make a diagnosis that way, and then amniocentesis or CVS, chorionic villi sampling, are both options now that we have.
So the chorionic villi sampling came in considerably later in your career.
That's right. I never learned how to do it because you had to have somebody. You had to get training somehow, and you couldn't train yourself. You had to go someplace to do it.
Mm-hmm.
And what ended up happening is that we had a faculty member come who had been trained where he was, and he's teaching other people now.
Sure. And it sounds like, we've observed an evolution in obstetrics and perinatology so that, I would say prior to 1960, the number one goal was to preserve the health and life of the mother. And, the outcome for the baby was desirable, but not the first priority. And as those outcomes for the mothers improved in the 60s, technology started to evolve that would allow us to actually try to assess the condition of the baby inside and begin to think in terms of fetal health and the like. And then perinatology evolved, and your focus was on a combination of the well-being of the mother and also doing a increasingly detailed assessment of the baby and finding ways to intervene and improve the health of the baby. So this is an evolution that has occurred, and it's gone from the two-dimensional ultrasounds that were done in the 70s to sophisticated genetic analyses being done in the first trimester.
Yes. I think, unfortunately, the maternal mortality in the United States is still embarrassingly low for industrialized countries.
Mm-hmm.
And so I think the focus has to come back to the mother a little bit more.
Mm-hmm.
And I know people are trying to do that. We have different diseases, but preeclampsia is still there, eclampsia is still there, high blood pressure is still there, diabetes is more than ever.
Mm-hmm.
So all those things are unfortunately still available.
I think the patients that your colleagues are being asked to treat have changed, whereas when I was a resident and we had a clinic, our average obstetric patient age was 19. and
Wow.
as we have this conversation, the average age of a woman giving birth in Massachusetts is over 30.
Wow.
And the incidence of diseases of aging is greater. The incidence of complications of infertility treatment is greater. And so the challenges being presented to the perinatologist have evolved and gone up to a significant degree.
I think also women with chronic illnesses were told not to have children, and they followed those directions a lot of times. Now they want to have kids, and
Right.
so now we have to just figure out how to take care of them because they're not going to listen to advice in many cases.
Right. So you're being presented with these challenges that had not been there before,
Yeah.
and so that also is having an effect on things. Sure. And substance abuse, was that an issue early on in your career?
Oh yes. So that was actually one of my areas of focus when I first got there, because it wasn't unique to Worcester. We had the same problem in San Diego, but what you had was a situation where the substance abuse treatment programs would stop taking care of a pregnant woman because they were uncomfortable.
Mm-hmm.
And obstetricians were not comfortable taking care of that group. So they wouldn't ask about the issue, because if they got a yes, I do use a heroin or whatever, then they didn't know what to do with her.
Mm-hmm.
Or how to take care of her. So one of the first things we did was work out a program with Spectrum so that patients could be managed together. And I think that made a difference. Many of them, we had a hepatitis epidemic essentially in the early 80s, I think. And we had at least 2 maternal deaths in a fairly short period of time from severe hepatitis infection. Mm-hmm. And it really was important to try and figure out how to get a handle on all of this. And
sure.
That's where methadone maintenance and some of the other ideas became pretty common.
Yeah. And I think you're right. The improvement that occurred during your career in obstetric in fetal outcomes has been fairly dramatic. When you entered, infant mortality in the 70s was probably 30 per 1,000 for the infant mortality. Mm-hmm. And as you finished your career, it was probably closer to 5.
Yeah.
And maternal mortality, we're talking about, as we had this conversation, in the ballpark of 1 in 10,000. Mm-hmm. In that range there. But it had been that for decades.
Yeah.
As the profiles of the obstetric patients has changed, that hasn't improved as much. So the other part that comes in is just changes in the healthcare system. When you started, when you were in medical school in early residency, they were just beginning to have government paid for health care. And most health care that was delivered was fee for service for those private patients who were fortunate enough to have insurance. And if patients did not have insurance, they would go to a clinic and receive charity care. That has evolved.
Mm-hmm.
And how has your perception of that been?
Well, I think Massachusetts is fortunate because they got into it covering maternity care sooner than the national push. And so I don't remember too many patients that we had as self-care. Although we had people who showed up late to care because they didn't perceive that they could get insurance. And even today, there are people that don't realize they can get maternity coverage soon enough. But our ability to see patients even in the first trimester has been pretty good. Where we ran into trouble was in, covering glucometers for diabetics and or supplies for diabetics or things like that were not covered in the routine insurance plans. And that's where the March of Dimes was a big help. They gave us glucometers and things like that for years. And I've always felt a loyalty to that organization for that reason.
And as we have this conversation, there are conversations regarding national health care plans. There are efforts underway to find some way to provide insurance for every person in the country. And roughly 5-10% of people are not covered by insurance as we have this conversation. Fewer in Massachusetts, probably 1 or 2% in Massachusetts. So the system is still working its way through this problem.
But even people that literally get off the airplane from somewhere else, and that was not unusual, we often found ways to cover them.
Yeah. And so what, in thinking about your career, are there other highlights or other points that you'd want to bring up?
Well, I guess the only thing I can do is mention just a shout out to the people that I work with, particularly the nurses. And eventually we developed a nurse practitioner in maternal fetal medicine who kept all of the doctors organized and was very big in bringing in computerized systems. That was a struggle for some of the older people in the division to learn how to do all that. Actually, one of the things that pushed me to retire was the development of Epic. It was coming and I'd have to learn something again, another whole system. As it was, ultrasound wasn't coordinated with the computer system that was in the hospital. The lab was a third computer system. Insurance was a fourth system. I mean, it was crazy. Now, eventually, everything's all organized under one.
Yeah.
But the nurses in the labor and delivery were excellent. The nurses in the clinic were excellent, and you couldn't run a program without their support.
You built a strong team.
Yeah, and they stayed a long time.
Yes. A good note to end on. Thank you for having this conversation with us.
Thank you.